Hello, everyone. I would like to present you my PhD topic titled as Residual Symptoms Following Total Knee Arthroplasty. So let's imagine a world where you get infected and you are having 60% of chance getting bloodletting instead of antibiotic therapy. Or let's imagine a world where you have headache and you have 60% of chance of getting trepanation instead of painkillers. Or you're having some psychiatric disease and getting lobotomy instead of normal pharmacotherapy. I wouldn't really want to live in that world, would you? Well, sadly, this is the case in ortho world. 60% of surgeons are using Esmarch tourniquet during the total knee arthroplasty surgeries without any guidelines or any evidence behind it. And the compromised blood vessels and nerves may lead to complications such as pain, hypoxia, or deep vein thrombosis. And in our systematic review and meta-analysis, we found that the application of tourniquet not only does not elevate the effectiveness of the intervention, but it elevates the risk of deep vein thrombosis by 1.62 times. Therefore, surgeons shouldn't use Esmarch tourniquet during total knee replacement. I'm András Zoltán Posta. I'm working at Semmelweis University Orthopedic Clinic. And as an ortho resident, I have a vision to operate people with knee osteoarthritis the best possible way. And in order to do that, we would like to study the different techniques of total knee arthroplasty. My first project is investigating the effect of Esmarch tourniquet during total knee arthroplasty surgery. So osteoarthritis is a degenerative disease which can cause pain and stiffness, and it's a leading cause of disability in adult population. And there are around 40 million cases, just the US alone. And the definitive treatment for this disease is total knee arthroplasty, and there are around 1 million surgeries yearly just in the US. So you may be wondering what Esmarch tourniquet, my title, was all about. You can see it on the screen. This is an inflatable device. You can put it on the thigh to prevent blood flow of the operated area. So one day I was operating another surgeon, not with my mentor, and I was surprised to see that he didn't use tourniquet. And when I asked him about that, he said that he not used to do it. Well, that was interesting. So after some research, I found out that this is the case worldwide. So 60% of surgeons are using this device and 40% are not, without evidence or guidelines. So our aim is to assess the impact of Esmarch tourniquet. Our clinical question is on the screen, and we are comparing operating with tourniquet to without tourniquet, and our outcomes are bleeding, surgery time pain, or thromboembolism. So after proving its feasibility, we did our search in 3 databases and got around 6,000 hits. And from that, with my help of with my lovely section per Landor Nemes, we narrowed it down to 40 RCTs. And then we did the same tabs for reference and citation chaser, and we got 8 new articles to include. So if you ask 10 orthopedic surgeons, why do they use tourniquet, 5 of them would say because it's easier to operate in a bloodless operational field. Well, you cannot really measure easy, but the closest thing you can do, you can measure surgery time. And it turns out after 4,000 patients at 30 RCTs, there are only 3 minutes shorter surgeries with tourniquet, which is clinically negligible. And if you know the fact that the application of the device is around 10-15 minutes, then you wasted per surgery 10 or 13 minutes. If you ask the other 5 surgeons why do they use tourniquet, they would say that they are using it because there are less blood loss with the application of it. Well, at least it's half true. So intraoperatively, as you can see on the upper corner, there is around 100 milliliters less blood loss intraoperatively. But if you look at the other picture, postoperatively, we have the same order of magnitude higher blood loss with the application of tourniquet. And at total blood loss, calculated total blood loss, or transfusion requirements, we had no difference at all. But this is the main figure. Like we are showing here the risk of deep vein thrombosis. And here we have a significant difference between the groups. We have 62% higher chance of getting DVT with the use of tourniquet. Of course, our study has strengths and limitations, you can see on the screen. And I have conclusion, you can see on the screen as well, but I would like to ask you to draw your conclusion. If you were an orthopedic surgeon, would you use this device or no? My manuscript is finished. I sent it to my supervisor, and I'm waiting for his approval. Then you can see my deadlines on the screen and the target journals as well. So after getting the results of my first project, I was really happy. I was about to go back to my clinic, like collect all the devices and throw them out. But when I was presenting my results to my clinic, they said that, okay, and what about the different subtypes of tourniquet? What about the cementation? And I was like, okay, what about it? And it turns out that under tourniquet, in a bloodless bone, you can glue the prosthesis better to the bone. So if you do it without tourniquet, it could lead early aseptic loosening, or it could lead to worse long-term outcomes. So I was like, all right, I need to do another project. So here is my second project. It's almost the same, but here we are comparing the different subtypes of tourniquet, and we are looking into long-term outcomes as well. Our clinical question, as I said, it's almost the same, but we are comparing different subtypes, and we included the cementation outcomes. And our hypothesis is the longer the tourniquet is applied, the worse it is for the patient. After proving its feasibility, we did the same steps with the same search key, and if you can look at it, we have 1,000 more articles found, so it proves it's a hot topic, and we had 72 plus 9 RCTs to include. Here you can see my first result I would like to show you from the second project. So there is a star-like shape. It shows us the direct comparisons between the subgroups. There are 4 major subgroups and 2 smaller subgroups. The 4 major subgroups are full tourniquet, when you apply it before the incision and deflate it after the suture. There is the half tourniquet, when you inflate it before the suture and inflate it before the incision and deflate it after the cementation. There is the cementation subtype, when you inflate it just before the cementation and deflate it right after. And there is the no tourniquet group, when you don't use it at all. And there is the 2 small subgroups, the CTC, OTC. These are just in 5 studies. And thicker the line is, there are more RCTs compared these 2 subtypes. So if you look at the bottom picture, you can see basically the greener it is, the more likely is the best intervention in the risk of deep vein thrombosis standpoint. If you look at the lines up there, it's showing the same. And I would like to say that the CTC and OTC has a very low number of RCTs with very low number of patients. And if we exclude them, there are clearly the no tourniquet is the best in both pictures. So my second project is here. I have some figures, but I am waiting for more pictures, of course. And yeah, after we just need to write the article. So as a summary, I have 3 projects. I only talked about 2 because the third one, I introduced it 3 times, and I didn't have time here to introduce it again. But we would like to submit the first one in a month, and the second one 3 months later. I would like to finish my presentation with the words from Weiner von Braun. Research is what I'm doing when I don't know what I'm doing. Thank you for your attention.
Thank you for the great and entertaining talk. I would like to ask the audience whether they have questions or remarks.
Thank you very much. Could we go back to the slide of your second project with the figures? Because I couldn't, I don't wear my glasses, I couldn't see.
You can come closer if you want.
So you said no tourniquet, like not wearing the tourniquet at all, had the best outcomes.
Yes.
What is the graph showing about the subgroups, such as the half tourniquet, before cementation, after cementation?
Yeah, so if you see the screen, like, this is the non-tourniquet one. These are the two ones, what I said that we would like to exclude, or at least do the analysis without them, because these are only like 3 or 4 RCTs from 80 or something. But this is the non-tourniquet, and then we have the other ones like cementation, half tourniquet, and then full tourniquet is reversed. And like the same with the green and red thing. And the funny thing is that most of these 60% of surgeons are using full tourniquet, which is really funny, which is the worst, clearly.
But any kind of use of the tourniquet actually increases?
Yes, from deep vein thrombosis standpoint, yeah. It's any kind of tourniquet is worse than no tourniquet.
Okay, thank you.
Yes, please.
Sorry, and I don't want to be provocative, okay? So
yes.
Apart from gaining your PhD, but what do we hope here now? So if you are showing the results, is that it's not the best idea to use tourniquets, so what would be the next step? Is it some policymaker suggestions or guideline recommendation would there be?
Well, I don't really know how it's going to turn up, because like orthopedic surgeons are insisting on what they learned. They would like to continue things do that way because they think it's the best way. Yeah, we would like to have guidelines to don't use tourniquet because it's clearly harmful. But we had this data. We had this data in the previous RCTs, and they are doing new and new RCTs about the same topic. And I don't know why, because it's clear that there is no difference in blood loss or surgery time or any other outcomes we had. But it's clearly worse in deep vein thrombosis. And just in the last 6 months, we had published 7 new RCTs in this topic. And I don't know why they keep doing this, asking this question and doing these RCTs, because we have clear data that it's worse. We don't need to use it. We shouldn't use it. So I don't know how it's going to turn.
Let's publish it in everywhere.
Yeah, yeah.
Are you planning to do maybe a trial sequential analysis, which would show there are no more studies, needed?
Obviously, we can say that. Yeah, I said it in the conclusion that we need more studies, further studies. Yeah, but you can see the results. So, yeah, we can say that we need more studies, but I think there are other areas you can look into in ortho field.
Okay, yes, please.
Thank you for this great presentation, very interesting. I have some trouble understanding the figure on the lower one.
Yes.
Is that the FT, the full tourniquet, is in red, because
yes.
that has the most risk for
yes.
deep vein thrombosis, and yet those numbers on the side show that it's 0 as in red and
yes.
green at the top.
Yes, so the numbers on the picture are the percentage of likelihood of that intervention being the best from the 6. So there are 10% chance the full tourniquet is being the best, but this is like really low. And there are like 70% chance of no tourniquet being the best. So these are likelihoods. Obviously, we cannot say that I'm sure this is the best, but yeah.
Yes, now based on your explanation, I understand the color coding, but you said that it's the risk of deep vein thrombosis, so maybe it's not exactly the same as what now you just explained. So the figure legend is not what you just explained right now. Maybe that's just a comment I made, but
okay. I will think about that.
Okay, thank you.
I also have a question. Maybe you have mentioned, but what about this aseptic loosening thing without the tourniquet?
Yes. So this is the cementation outcomes I said. Like we didn't include that in the first project. So they said that there is a theory that if you are doing the surgery under the tourniquet, it would have better outcomes, so less aseptic loosening.
Did you do any analysis?
At the first project, no. At the second one, we tried to collect data. And the funny thing is that from these 80, I don't know, 83 or something RCTs, they only included three times. Like they wrote 3 times about the cementation and no long time aseptic loosening or anything, just the cement mantle thickness, which is like how thick the cement under the prosthesis is after the operation, but no long-term data. So it's really funny. It's the same with Nandor's project. Like ortho guys didn't really like to do long studies because it's, I don't know, hard or anything. So we don't have long-term data about it.
I see. So,
but right now, if we don't have anything besides it, but we have a lot of things against it, then we shouldn't use it, I think.
I see. Yes, please.
Just a quick
Last
question.
question.
Congratulations. I have a question about the surgical site infection or the postoperative prosthetic joint infection. Do you have any data about it? Because as an antibiotic prophylaxis, I think that you give cefazolin or kind of penicillin.
At our clinic, yeah.
Yeah, but when you use the tourniquet, the pharmacokinetics change because the blood flow is close.
Yes, it's harder to get the antibiotics there where the wound is. That's what you are meaning.
Yes, yes, yes.
So this is another point next to that we shouldn't use tourniquet.
Yes.
Yeah, we didn't include these outcomes in our study, but logically this is another thing against tourniquets.
Thank you.